Imagine having a chronic fiery pain that actually makes your own skin shed from the inside out. Like for years, you go to doctors and they just keep handing you, standard yeast infection creams or...
Right, or antibiotics that do absolutely nothing.
Exactly. The pain during intimacy is excruciating, the tissue is completely raw, and nobody seems to know why. So today, we're doing a deep dive into a heavily misunderstood and, frankly, often misdiagnosed nightmare in women's health. It's called desquamative inflammatory vaginitis, or DIV.
Yeah, and more importantly, we are looking at the mind-bending microscopic solution scientists are using to actually stop it, which is highly purified DNA extracted from the gonads of farmed fish.
I mean, I know that sounds completely like science fiction.
It really does, but the reality is grounded in some of the most elegant biochemistry we've seen in regenerative medicine. Today's stack of sources takes us through clinical guidelines, real-world observational studies on patients who have suffered with this for decades, and cellular pathology reports.
Right. And those reports map out exactly how these marine DNA fragments, which are called polynucleotides, by the way, how they hack human cellular receptors to just completely halt this aggressive inflammation.
Yeah, it's fascinating.
So whether you are a clinician trying to solve a diagnostic puzzle, or someone navigating mysterious health symptoms, or maybe you're just intensely curious about how a local application of DNA can reprogram the human immune system, this deep dive is for you.
Definitely. But, to make sense of the cure, we really need to understand the crisis first.
Right. We have to look at the fire before we can understand how the water puts it out. So let's look at the reality of DIV. What is actually happening here?
Well, the clinical presentation is just staggering, especially when you contrast it with how frequently the medical system completely misses it. DIV is a chronic, rare form of vaginitis.
And who does it usually affect? Like, is there a specific demographic?
It can occur in women of all ages, but the data shows a really significant spike in perimenopausal and postmenopausal women. And the daily reality for these patients is just severe.
Yeah, the observational studies we read describe a really grim situation. Patients report copious, purulent discharge.
Purulent meaning it's thick and pus-like.
Right. And it can be yellow, green, and often blood-stained. The vaginal walls themselves become fiery red. Clinicians often note a spotted rash. Like, what was the medical term for it?
Petechiae. It's an ecchymotic rash, which basically means pinpoint bleeding right under the skin.
Oh, wow, that sounds incredibly painful.
It is. And of course, this leads to dyspareunia, which is severe, sometimes completely debilitating pain during intimacy.
And the name itself, desquamative,
Yeah.
that actually tells us mechanically what's happening, right?
Exactly. Desquamation means shedding or sloughing off. The vaginal mucosa, which is the protective skin lining the vaginal canal, is actively peeling away.
Just peeling right off.
Yeah, under normal conditions, this tissue has multiple thick protective layers. But in DIV, the tissue becomes radically thinned out, which exposes the underlying connective tissue.
And that underlying layer is not meant to be exposed.
Not at all. It's heavily populated with raw nerve endings and really fragile blood vessels. That's what creates the intense pain and the bleeding.
So a patient walks into a clinic with this terrible discharge and burning. And the standard reflex from the physician is almost always, oh, this is a severe yeast infection or it's bacterial vaginosis.
Right, and they get a standard prescription, go home, and a week later, they are in just as much pain.
It's awful. Women in these observational studies routinely describe suffering for 3, 5, sometimes even 10 years.
Yeah, subjected to round after round of antibiotics or antifungals that just don't work. The real tragedy is that DIV is primarily a diagnosis of exclusion.
Meaning you have to rule everything else out first.
Exactly. You have to rule out yeast, trichomonas, standard bacterial infections, but there actually are very specific objective criteria to identify DIV if a clinician just knows to look for them.
Right. Our sources highlight 4 distinct markers. First, the vaginal pH is highly elevated. A healthy vagina is acidic, but in DIV, the pH shoots up over 4.5, sometimes even climbing past 6.
Which is a huge shift.
Yeah. Second is a negative whiff test. When a doctor applies potassium hydroxide to the discharge, bacterial vaginosis typically produces a really strong, fishy odor. But in DIV, there is no odor.
Right, because it's not that type of bacterial overgrowth.
Exactly. Third, there's a complete lack of lactobacilli, which are the healthy, protective bacteria that usually maintain that acidic environment. But the real smoking gun is what you see under the microscope, right?
Oh, absolutely. When a clinician takes a swab, mixes it with a little saline water on a glass slide, a saline wet mount, and looks through the lens, the field of view is just chaotic.
What do they see?
You don't just see a few scattered white blood cells reacting to a minor irritant. You see massive overlapping sheets of inflammatory white blood cells. And crucially, you see a 1-to-1 ratio of these white blood cells to peribusal cells.
Okay, let's unpack those peribusal cells.
Yeah.
Because those are immature skin cells, right?
Right. They belong deep down at the very base of the tissue layer. They anchor the tissue to the body. They absolutely should not be floating freely in vaginal fluid.
So seeing them in the fluid means, what, the top layers are just gone.
Exactly. The mature surface layers have been completely stripped away. The skin is shedding so violently and at such a fast rate that the deep, immature foundation cells are just being washed out into the open.
It makes me think of, like, a faulty fire sprinkler system inside an office building.
Oh, that's a great analogy.
Right. Like, the body's immune system detects a massive fire, a threat that completely isn't there. It turns on the inflammatory sprinklers, floods the room, and absolutely refuses to turn them off.
And the water damage just ruins everything.
Exactly. The drywall, which is the vaginal lining, becomes soggy, crumbles, and just washes away, leaving the bare studs exposed.
Yeah, the compounding damage is just relentless. The immune system is trapped in this self-destructive loop. And while the exact trigger for DIV is heavily debated, the consensus points strongly toward a localized autoimmune dysfunction.
So the body's just attacking itself.
Right. We frequently see it linked to other systemic immune conditions, like lichen planus, rheumatoid arthritis, or Crohn's disease.
And the sources even mention cases where the sudden onset of DIV was triggered by something totally weird, like a severe bout of diarrhea.
Yeah, or a heavy course of systemic antibiotics that just shocked the local microbiome.
So the building is flooding and the walls are crumbling. Standard medical treatments for DIV usually involve localized vaginal clindamycin, which is a really strong antibiotic.
Or highly potent topical steroids like hydrocortisone.
Right. And the goal there is just to suppress that hyperactive immune response.
Which works temporarily. The study showed these treatments can induce remission, but relapse is incredibly common the minute the treatment stops.
It's a temporary pause button, not an actual repair, which finally brings us to a totally different approach. Polynucleotides, or PN.
Yes. This represents a massive shift from traditional pharmacology into the realm of regenerative medicine. Polynucleotides, specifically formulated using high purification technology, or PN-HPT, are highly purified DNA fragments.
Like, how big are we talking?
We are talking about long polymer chains of DNA ranging from 50 to 2,000 base pairs in length.
Okay, wait, hold on. The sources clearly state these DNA fragments are extracted from the gonads of farmed salmon and trout.
I know.
We are taking raw fish DNA and putting it directly into raw, heavily inflamed, peeling human tissue. Why doesn't the human immune system immediately sound the alarm, assume this is a massive parasite, and just attack it?
It's a totally fair question. The lack of an immune response comes down to the universal nature of biology and really the extreme multi-step purification process.
Okay, explain that.
Well, DNA is the universal operating language of all life on Earth. A nucleic acid is a nucleic acid, whether it comes from a human, a plant, or a trout. The human body does not mount an allergic response to the raw biochemical letters of DNA.
Wait, really? So what actually causes allergies then?
What triggers an allergic or immune response are the proteins and peptides that are associated with the source animal.
Oh, I see. So it's not the blueprint itself that triggers the alarm. It's the envelope it was delivered in.
Exactly. That's a perfect way to put it. The high purification technology strips away all the biologically active proteins, peptides, and lipids from the fish.
So it's just pure DNA.
Right. What remains is a pure, naked DNA fraction that carries virtually zero allergic potential. And because of this absolute purity, these polynucleotides function and are regulated in many regions as a CE-marked medical device rather than a traditional drug.
That is wild. So physically, when this clear, purified DNA gel is introduced into that dry, painful, thinned-out vaginal environment, usually via a vaginal ovule.
Yes, usually an ovule.
The immediate effect is mechanical.
Yeah.
Polynucleotides are intensely hydrophilic. They love water.
They really do. They instantly bind to water molecules in the surrounding tissue to form this dense, three-dimensional gel matrix.
Which hydrates and physically cushions the atrophic tissue. But the real biological magic happens through something our sources call the salvage pathway. What is that?
So the salvage pathway is basically a metabolic shortcut. Normally, when a cell needs to divide or repair itself, it has to synthesize new DNA and RNA from scratch.
Which takes a lot of energy, I assume.
A massive amount. That process is called de novo synthesis. And in a tissue that is actively being destroyed by inflammation, the local cells are just completely exhausted. They don't have the energy reserves to build repair materials.
So our native enzymes, like DNases, they slowly chew up these injected fish DNA fragments.
Right? They break them down into their absolute base components.
Right.
Nitrogenous bases, nucleosides, and nucleotides.
So we are essentially giving a disaster zone, not just a tarp to cover the damage, but a massive free shipment of pre-cut lumber and bricks.
Exactly. The exhausted human cells salvage these pre-made blocks to synthesize their own human DNA and RNA, saving just massive amounts of energy.
Wow. So the efficiency of the salvage pathway gives the local cells the metabolic capacity to actually begin structural repair.
Yeah. But simply providing raw materials doesn't explain how the overarching information is stopped.
Right. Like we said earlier, dropping off lumber at a burning house doesn't put out the fire.
Exactly. To understand the fire extinguishing mechanism, we have to zoom way in, past the tissue layers, past the cells, right down to the receptors on the cell membranes.
This is the core biochemical revelation of the whole deep dive, right? How polynucleotides actually downregulate the hyper-inflammatory cascades in chronic DIV.
Yes. So as the polynucleotides break down, one of the primary nucleosides they release into the tissue is adenosine.
Okay, adenosine.
And this adenosine floats through the extracellular space until it finds and selectively binds to a very specific doorway on the surface of local immune cells, like macrophages, and tissue-building cells, like fibroblasts.
And that doorway is called the adenosine A2A receptor, or A2AR.
Right. When adenosine clicks into the A2AR doorway, it triggers a really profound signaling cascade inside the cell. The receptor activates an internal enzyme called adenylate cyclase.
Okay, adenylate cyclase, what does that do?
You can think of it as an emergency manufacturing plant. When it's turned on, it rapidly synthesizes a messenger molecule called CAMP-P cyclic adenosine monophosphate.
So intracellular levels of CAMP suddenly surge.
Exactly. And that surge wakes up another protein inside the cell called protein kinase A, or pKa.
Right, and then pKa travels toward the nucleus and phosphorylates, or basically activates a transcription factor called cARB.
You got it. And the entire point of this complex biochemical relay race, from the A2A receptor to CAMP to pKa to cREB, is to stop a very specific villain driving the DIV symptoms.
Which is a protein complex called NF-kappa B.
Exactly. In a healthy temporary immune response, NF-kappa B is a critical tool for fighting off acute infections.
But in a hyperinflammatory state like DIV.
It's completely out of control. It acts as a primary transcription factor, migrating into the nucleus of the cell and instructing the DNA to just pump out massive quantities of inflammatory signals.
So kappa B is like a riot leader holding a megaphone, constantly yelling at the local immune cells to keep attacking the vaginal tissue, just keep burning the building down.
That is a brilliant way to picture it. Normally, this riot leader travels straight into the nucleus to broadcast his message.
But the adenosine from our broken down polynucleotides acts like a hostage negotiator.
Yes.
It binds to the A2A receptor on the outside of the cell, sends that calming CMP messenger inside, and the resulting cascade physically blocks NF-kappa B from entering the nucleus. Just unplugs the riot leader's megaphone.
And that silences the specific cytokines driving the symptoms. The clinical data maps the resulting cytokine shift beautifully.
What does that shift look like?
By blocking NF-kappa B translocation, the production of pro-inflammatory cytokines plummets. We see rapid, massive drops in tumor necrosis factor alpha, interleukin-6, interleukin-1 beta, and interleukin-8.
The sources also highlight a massive drop in nitric oxide, which is super interesting.
Oh, yeah. Nitric oxide is a potent vasodilator. It forces blood vessels to widen and become leaky.
And that leakiness is exactly what causes the vaginal walls to look so fiery red, right? And it produces the petechiae, those tiny spotted bleeding rashes we talked about.
Exactly. Shutting down the nitric oxide stops the vascular leaking and allows the tissue redness to fade. But the A2AR activation doesn't just suppress the harmful signals. It actively promotes healing, too.
Right. The same cascade that blocks NF-kappa B simultaneously forces the cell to increase its production of interleukin-10.
Yes. IL-10 is a powerful anti-inflammatory cytokine. It basically signals the surrounding immune system to stand down, promoting immune tolerance.
The sources also mention a whole alphabet soup of other pathways that get dialed down, like the MAPK pathways, ERK, JNK, P38, and the JAK-STAT axis.
Yeah, to make sense of that, we can think of the JAK-STAT pathway like the cell's internal telegraph system for receiving distress signals from neighboring cells.
Okay, so by calming the JAK-STAT axis, the polynucleotides are basically cutting the telegraph wire.
Right. Even if neighboring cells are panicking, the signal doesn't get through, and the cell stops reacting to the surrounding chaos.
The net result is just a fundamental shift in the cellular environment. We aren't just masking the pain with a topical anesthetic.
No, and we aren't using a sledgehammer corticosteroid that shuts down the entire local immune system indiscriminately, which would leave the patient vulnerable to other infections.
Right. We're using a biological key to hack a specific receptor, shifting the local macrophages from an aggressive attack mode into a tissue-clearing repair mode.
Exactly.
But, okay, the riot is over, the megaphone is unplugged, and the panicky telegraph wires are cut. You're still left with a completely wrecked building.
Yeah, the damage is still there.
The cells are stripped, the parabasal layers are exposed, the tissue is raw. How does the body actually rebuild that structural damage so the patient gets their quality of life back?
Well, with the inflammatory suppression lifted by that adenosine cascade, the local fibroblasts, which are the specialized cells responsible for building structural scaffolding, they're heavily stimulated by the remaining polynucleotides.
They finally wake up.
They wake up and begin synthesizing the raw materials of healthy tissue, type I and type 3 collagen and elastin.
And this directly addresses the desquamation, the shedding.
Yes. As the fibroblasts lay down new collagen and elastin, the thinned, fragile mucosal lining begins to physically thicken.
It regains its stretch, its resilience, and its ability to withstand friction without tearing or bleeding.
And the sources point to a very specific repair mechanism occurring at the cellular borders. The restoration of tight junction proteins, specifically one called claudin 1.
So if the new collagen provides the structural bricks of the vaginal wall, claudin 1 is the mortar holding those bricks tightly together.
Exactly. By repairing claudin 1, the natural barrier function of the vaginal epithelium is completely restored.
Which is vital because a strong, tight barrier keeps opportunistic bacteria out.
Right. DIV patients suffer from frequent secondary infections because their mucosal barrier is compromised. Sealing those microscopic gaps prevents the outside world from triggering further localized infections.
The repair process also involves angiogenesis, right?
Yes. The polynucleotides stimulate the release of VEGF, vascular endothelial growth factor.
And VEGF signals the body to sprout new, healthy microblood vessels, bringing fresh oxygen and nutrients to the regenerating tissue.
And the amazing part is it manages to do this without causing fibrotic scarring, which is a major risk when tissues heal from chronic long-term injuries.
That is incredible. And in modern clinical practice, these polynucleotides are rarely used in isolation, right?
Correct. The ovules prescribed for DIV frequently combine the PN with hyaluronic acid, or HA.
Because the HA provides intense immediate moisture. It rapidly relieves the severe dryness and dyspareunia on the surface layer.
While the polynucleotides absorb deeper into the mucosa to perform that long-term cellular reprogramming and receptor downregulation.
Honestly, reading through the sequence, halting the cytokine riot, synthesizing fresh collagen, sealing the tight junctions with claudin 1, it sounds incredibly comprehensive.
It is a profound mechanism.
But the question a patient who's been suffering for 10 years will ask is, is this a miracle cure for DIV?
It's tempting to call it that, but the clinical literature is extremely careful to ground expectations.
Why is that?
Because DIV is an extraordinarily complex condition. It's deeply rooted in systemic autoimmune tendencies that we just do not fully understand yet. It is notoriously stubborn.
So it's not a permanent cure.
Right. While polynucleotides are a powerful, biologically elegant tool for cellular biostimulation, heavily supporting barrier integrity and forcing the tissue out of an inflammatory phase, they are not a permanent cure.
So patients should expect this to be more of a management strategy rather than a one-and-done fix.
Exactly, a highly advanced management strategy. Because DIV is chronic, patients often require maintenance therapy, occasionally needing to use the ovules to keep the tissue stable.
And they still need ongoing medical assessment.
Absolutely. The ultimate goal is profound symptom relief and the restoration of a normal quality of life without relying on long-term steroids.
Let's pull all of these threads together. We started our deep dive today exploring the profound misery of desquamative inflammatory vaginitis.
A painful, peeling, hyper-inflammatory state where the body's immune system relentlessly attacks its own mucosal lining, washing away its protective layers.
And then we introduced marine-derived polynucleotides, initially fighting the mental hurdle of utilizing fish DNA.
Right, only to uncover the incredible purity of the technology and the brilliant energy economics of the salvage pathway.
We tracked those DNA fragments as they broke down into adenosine, binding to the A2A receptor on the surface of local immune cells.
And we mapped the internal CANMP cascade that unplugs the inflammatory megaphone of NF-kappa B, halting the release of nitric oxide and tissue-destroying cytokines.
And finally, we saw the tissue awaken its fibroblast to lay down fresh collagen, elastin, and tight junctions, physically rebuilding the vaginal barrier from the inside out.
It really highlights the incredible potential of harnessing our own cellular receptors, and, it leaves you with a final thought to ponder, building on the mechanisms we've explored today.
What's
Well, if manipulating the A2A receptor with simple, purified DNA fragments can effectively halt localized autoimmune-like inflammation in the vaginal tract without the systemic, long-term side effects of heavy corticosteroids, could this exact same nucleotide salvage pathway become a master key?
Oh, wow. You mean for other conditions?
Exactly. Could scientists adapt the specific mechanism to reverse other chronic treatment-resistant inflammatory mucosal diseases anywhere else in the human body?
That is a massive thought to chew on. The idea that the solution to our most complex, deeply entrenched inflammatory fires might just be providing the perfect cellular water.
Thank you for joining us on this deep dive. Keep questioning, keep learning, and we will catch you next time.